Assalamu alaikum and a very good afternoon. And I welcome you all to the last session of HemeCon 2022. In memory of Dr. Tahir Shamsi, we have renamed this session to Dr. Tahir Shamsi Memorial Session, and our topics in this session will be related to stem cell transplant. I have great pride in introducing the chair of this session, Major General retired Parvez Ahmed. He has established and currently is heading the clinical hematology and bone marrow transplant unit at the Quaid-e-Azam International Hospital in Islamabad. Our co-chair for the session, Dr. Salman Naseem Adil, who has also established the Bone Marrow Transplant Center here at Awan University. He's a professor and consultant hematologist at the Departments of Pathology, Laboratory Medicine, and Oncology here at Awan University. Our panelists for today's session include Dr. Tariq Mahmood Satti, who's a consultant hematologist at Shifa International Hospital, Islamabad, Dr. Shahzad Sarwar, assistant professor assistant professor, Center of Hematology and Bone Marrow Transplant at Gambard Institute of Medical Sciences, and Dr. Syed Nasir Abbas Bukhari, who's a pediatric oncologist and hematologist, and he's heading the bone marrow transplant unit at Children's Hospital, Lahore. With this, we begin with the first talk of our session, and our speaker is Dr. Bipin Savani. Dr. Bipin is a professor of medicine, hematology, and oncology, and is also the director of the long-term transplant clinic at the Vanderbilt Ingram Cancer Center. Dr. Savani's area of specialization is in the treatment of hematological malignancies, transplant, and cellular therapy, and his primary field of research is in the long-term follow-up transplantation clinic after stem cell transplant and cellular therapy. And this clinic also supports regimen-related toxicity, supportive care, and hematological malignancies. Dr. Savani has published over 500 peer-reviewed articles, reviews, book chapters, editorials, perspectives, and commentaries in the field of hematological malignancies, stem cell transplant, and cellular therapy. He's an associate editor of the British Journal of Hematology, Bone Marrow Transplantation, and Transplantation and Cellular Therapy. And he's also the co-editor in chief of Clinical Hematology International. With such an eminent profile and a dear friend, Bipin, thank you so much for accepting the invite from PSH. And we can't wait to hear your talk on prevention of relapse after stem cell transplant in acute myeloid leukemia.
Thank you all for inviting me to this virtual PSH conference. So in next 20 minutes, I'm going to review how we can prevent relapses after transplantation in acute myeloid leukemia. I have no conflict of interest to disclose. As you know, relapse after transplantation is a painful event. We feel it, right? This is one of the nice registry publications, the IBMTR study, our study, outcome of AML patient relapsing after transplantation. You can see here, those patients relapsing within 6 months, dismal outcome. 1 year survival, 10 to 20%, and 3-year survival, 4 to 5% in the range. And those older adults, worst possible scenario, if they relapses within 6 months or within a year. We know that early relapses have worst possible outcome. But our major problem is most relapses occurs within 6 months post-transplant, when you can't make any major changes to control the relapses. This is one of our acute leukemia working party EBMT study on outcome after use of two most intense ablative regimen in patients with refractory acute myeloid leukemia. You can see here, those patients who relapse, more than 90% a relapse occur within 6 months of transplantation. So, and what is our menu for those patients who relapse after first allo transplant? Listed here, but as you know, not so effective. Our menu is not so effective in most patients. Our relapse management menu, pretty unchanged for past 10, 15 years, almost 2 decades now, except more clinical trials for post-transplant relapse management. Here, goal is to get disease control with investigational or novel drugs, and then either second transplantation or DLI. And many a times we prefer second transplantation. So literally, two main options, second allo or DLI after disease control. Now, prognostic factor for second transplant remain unchanged for past almost 10, 15 years now. Factor associated with outcome after second transplant reviewed here. Despite this limitation, we always debate how best we manage post-transplant relapses. In our Monday transplant meeting, where we discuss all upcoming new transplant patient, discussion remain around, do we use same donor, different donor, impact of prior chronic GVHD, outcome of second transplant, can we do chemotherapy plus DLI, can we do chemotherapy or second transplantation. Main and only reason for all these issues is lack of prospective data. And there is none ongoing comparing second transplant versus DLI or other options. Our other major problem is only 10 to 15% of patients who relapse after transplant can be a candidate for second transplant. Let's say patient received second transplant, but you can see here 2-year survival in the range of 20% among highly selected patients who received second transplant. So our best option is to use all possible weapons to prevent relapse after transplantation, right? Let me start with this nice real case scenario. 68-year-old FLT3 ITD-AML required 2 induction prior to achieving CR1, then underwent 2 cycles of HIDEC, received RIC-MER transplant, day 13 grafted, 100% donor, FLT3 negative. Because of high-risk patient, restarted on maintenance sorafenib from day 45. And goal is to prevent relapse after transplantation. Let's review some data. These are some standard of care option to relapse after allotransplantation in acute myeloid leukemia. Let's start with conditioning regimen. Conditioning regimen intensity matters. If you hit hard, you get the benefit. I'm sure you're all aware about this BMT-CTN trial, phase 3 randomized trial comparing reduced intensity versus ablative regimen in AML or MDS, which is a BMT-CTN study. This is a long-term data of the study recently published. Reduced intensity result in lower TRM, but very high risk of relapse compared to ablative regimen, with statistically significant advantage of ablative regimen in terms of relapse-free survival. So this data support the use of ablative regimen as a standard of care for fit patients with AML or MDS. Now, question is, how do we intensify regimen, especially in older patients? Let me review some recent ASH study, ASH presentation. Fractionated busulfan regimen. Main idea is you can reduce the toxicity and related mortality of intense regimen by simply giving it over a long period of time. Conditioning regimen was fractionated bu with target busulfan AUC of 20,000 given over a period of 2 to 3 weeks. Busulfan AUC 20,000 equivalent to busulfan of 12.8 milligram per kilogram IV busulfan. And fractionated busulfan regimen is considered more intense than busi regimen, well tolerated in older patient, MD Anderson data. Fractionated bu myeloablative, you can see here, decent outcome. Median age, 65 years in patient receiving allotransplantation for AML. It's my favorable regimen. I call it ablative regimen for elderly patient. This is author's recent presentation at the ASH meeting a few months ago. Study comparing methotrexate tacrolimus versus PTCY as a GVHD prophylaxis for the fractionated busulfan regimen. You can see here lower severe chronic GVHD with post-transplant site compared to tacrolimus methotrexate as a GVHD prophylaxis. You can also see here lower non-relapse mortality after PTCY compared to tacrolimus with this fractionated BU regimen. Now, in addition, this longer duration of conditioning regimen allows addition of targeted agent like venetoclax, commonly used drug nowadays for most indication, or many other agents which may be synergistic with conditioning regimen and may further improve disease control with this regimen. Adding venetoclax with conditioning regimen, it was presented by Dr. Popat as a poster presentation here for your future reference. Venetoclax 400 milligram daily given from day -22 to day -3 with fractionated view. Azoles were avoided due to drug interaction and possible toxicity. GVHD prophylaxis was again PTCY. Median follow-up was short, 8 months, reasonable. 1 year survival, 84%. Progression-free survival, 77%. Author concluded that venetoclax can be safely added to the fractionated busulfan regimen. This is another regimen, myeloablative fractionated, now with sorafenib in patient with AML, a result of phase 1 clinical trial, again presented few months ago. As I mentioned before, longer the conditioning duration, it allows addition of oral targeted agent, which may be synergistic with conditioning regimen and further improve the disease control. Dose of sorafenib was varied among the 4 value, 200, 400, 600, 800, administered day -24 to day -5, and restarted sorafenib after engraftment for up to 1 year. Excellent outcome. Again, you can see here, progression-free survival 1 year, almost 90%, relapse only 5%, non-relapse mortality again around 5%, and low GVHD. You can see here overall survival, progression-free survival, excellent data, relapse rate, NRF, nicely shown in the Kaplan-Meier data here. Author concluded that maximum tolerated dose and dose for phase 2 sorafenib with myeloablative fractionated busulfan regimen was 400 milligram twice a day. Survival data appear promising. You can see, you have seen this. Now phase 2 study is ongoing. What else we can do to prevent relapses? Maintenance or preemptive therapy after transplantation. Nice review article in BBMT. New name of the journal is TCT. Targeted agent have allowed the introduction of maintenance therapy after allotransplantation. Preemptive and maintenance approach have the potential to decrease the disease relapse after transplantation, and that's what we know. So what are our choices? Some of the common choices are listed here. Let's review each choices and relevant important clinical data. I'm sure we are all aware about this randomized clinical trial. It only published randomized phase 3 study. There is one ongoing in the UK using oral azacitidine. Study results showed no benefit of azacitidine maintenance post-transplantation. Didn't make sense, right? Because more programs are using maintenance azacitidine post-transplant, especially in high-risk patients. So I communicated with Dr. Richard Champlin, a senior author, and protocol PI, Dr. Marcos de Lima, as soon as this paper was out. I questioned, what is their practice right now based on this data? So Dr. Champlin replied, no difference between maintenance versus no maintenance, but many people dropped out without receiving the full treatment. And Dr. de Lima replied, trial was plagued by lots of problems. Sadly, only few cycles were administered, and he said he has been diligently doing maintenance treatment despite the above result in terms of his clinical practice. Multiple ongoing clinical trials of AML maintenance agent after transplantation, including oral azacitidine maintenance after allotransplant, and many others. I have summarized the list here with reference number in case you want to review online. More ongoing trial listed here for your reference. What else we can do? We need to make sure we prevent possible relapses after transplantation. Prophylactic and preemptive DLI. This is one of our EBMT study published just few months ago in November. Nice study. DLI were administered preemptively, pre-DLI, for minimal or measurable residual disease, we call it MRD, and or for mixed chimerism. So those patients who had MRD positive or mixed chimerism received preemptive DLI called pre-DLI, and prophylactic DLI in those high-risk patients with full chimerism but molecular negative. Median interval from allo transplant to DLI was about 6 months, and this is the time generally we considered first DLI. 5-year leukemia-free survival was 58% and overall survival was 64%. Risk of acute chronic GVHD was low, and risk factor for DLI-induced GVHD listed here, including age more than 60, advanced disease at transplant, short time interval from transplant, and prior history of grade 2 or higher GVHD. Nice graph, great outcome. Outcome of DLI for mixed chimerism and for high-risk disease was almost similar and excellent. 5-year survival in the range of 60%. Now, post-transplant maintenance FLT3 inhibitor has changed the outcome of FLT3 positive AML. My case history I presented, we gave maintenance treatment. And if you recall our first publication on FLT3 AML outcome before we started maintenance, it was published in 2012. 2-year survival was only 20% without doing maintenance treatment in reduced intensity regimen. So let's review briefly this randomized study. Randomized placebo-controlled double-blind study, phase 2 trial, SORA-MAIN trial, 83 patients with FLT3 ITD positive AML and CR post-transplant, randomized to receive 20 months of sorafenib or placebo. Median follow-up, 42 months, almost 4 years. 2-year relapse-free survival probability was 53% in the placebo group versus 85% in sorafenib group, almost all cured receiving maintenance treatment. Sorafenib maintenance reduced the risk of relapse and death after transplant for FLT3 ITD positive AML, despite, remember, majority of patients in this study received RIC regimen. You can see here excellent graph. Blue line represent the treatment of sorafenib. Now question is, how do we identify patient at risk of relapse after transplantation? I mean, other than disease risk. If high risk, we know they're going to relapse. We want to see other features also. So we can strike early and prevent relapses. This is a nice study presented by Dr. Lowe from Dr. Charles Craddock group and other UK member group. Post-transplant MRD status and T-cell chimerism predict outcome in patient with algrafted for AML MDS. Prospective study, again presented in December ASH meeting. As we all know, full donor T-cell chimerism serves as a biomarker of GVL, and mixed chimerism reflects persistence of bidirectional tolerance. Nice figure here, same group presented in recent Blood Advances paper. So in this study, author reported that in this prospective correlation of impact of post-transplant T-cell chimerism and MRD in patient allografted for AML and AMDS. This is a FIAGRO study designed for your reference. 186 patients from FIAGRO study, prospective randomized trial, total 780, almost 800 sequential sample. Prognostic significance of post-transplant MRD from each sampling time point was assessed by landmark analysis. High frequency of post-transplant MRD positivity occurred at day plus 42 and day plus 3 months after transplant. You can see here nicely in the table. This is their outcome. 2-year overall survival of day plus 42 MRD positive patient was only 31% compared to 67% in MRD negative patient at day plus 42. 2-year cumulative incidence of relapse day first 42 MRD positive was 92% versus only 23% relapse when MRD negative at the same time point. Very predictable. Day plus 42 MRD was associated with more rapid relapse kinetics compared to when MRD was detected at the later time point after transplantation. So we can predict as early as day plus 42. Slide shows multivariate analysis, post-transplant MRD positivity as a time-dependent variable significantly reduced the relapse-free survival independent of pre-transplant MRD, even when adjusted for other known variables. So how does post-transplant chimerism and MRD influence the outcome? You can see here, full donor chimerism associated with improved overall survival and relapse-free survival. Nice numbers here. In patients with mixed donor chimerism at 3 months and at 6 months, and presence of MRD at the same time point associated with decreased overall survival and relapse-free survival. In contrast, in patients with full donor chimerism at month 3 or at month 6, even though they were MRD positive, they were a small number, but even though they were MRD positive, their outcome was equivalent to MRD negative patient. Solid message. If you have MRD positive around day plus 42, you have more than 90% chance relapse if you don't act. If you have a mixed chimerism at day plus 3 and day plus 6 post-transplant, day plus 3 and day plus 6, if you have a mixed chimerism at month 3 and month 6 post-transplant, and if you have an MRD positive at this point, outcome is poor if you don't act. So this data identify patient population early post-transplant who are at high risk of post-transplant relapse and can be targeted easily so we can prevent relapse after transplantation. This is my summary slide. Disease relapse after transplant is the most painful event during transplant procedure, right? We cannot change the patient's age. We cannot change the patient's existing comorbidity. We cannot change patient's disease risk, but we do have some option. Some of our common menu including selecting the best conditioning regimen, adding targeted agent, disease and chimerism monitoring, preemptive therapy, including maintenance and DLI, and more clinical trial. I thank you very much for your attention, and I'll be happy to answer your question. Please send me email or call me on my cell phone number.
Thank you so much, Dr. Savani, for that review. You are absolutely right. There are a couple of questions, and if we can take them at the end of the session. Our next speaker for the session is Dr. Farrukh Awan. Dr. Farrukh is an associate professor in the Department of Internal Medicine at UT Southwestern Medical Center, and he's also the member of the Division of Hem-Onc at the Harold Simmons Comprehensive Cancer Center. Dr. Awan is a member of several professional organizations, including the American Medical Association, the American Society of Clinical Oncology, and the American Society of Haematology. He is also the recipient of the Young Investigator Award from the American Society of Clinical Oncology and the Clinical Career Development Award from the Lymphoma Research Foundation. Dr. Awan has delivered scores of presentations, administered multiple grants and clinical trials, and has published numerous academic articles and book chapters. His clinical focus is on treatment of leukemia and lymphoma and transplant. And today, Dr. Farrukh will talk about maintenance therapies for lymphomas after autologous transplant.
Hello, everyone. Assalamu alaikum. I'm Farrukh Awan from UT Southwestern, Dallas, Texas. And I would like to thank the organizers for giving me the opportunity to present at HemCon. I want to wish you all a very happy new year, and hopefully this year would be better for all of us and safe for all of us and our families. So very excited to be here today, and I look forward to a nice, healthy discussion. It's been a while, and I wish I was doing this in person, but this is the second best, I guess. We're so used to this now. So the topic of my talk today is maintenance therapies for lymphomas after autologous stem cell transplants. These are my disclosures. So, when you're talking about maintenance treatments after autologous transplant specifically, and I limit my discussion to only autologous stem cell transplants because with the allogeneic stem cell transplants, it adds another level of complexity to it. So we're focusing on auto transplants only. And I think there are two basic principles to grasp here. So if you talk to a purist, for them, the maintenance option should only be utilized if it improves overall survival. Now, in the current era, it's very hard to come up with something that would categorically improve overall survival, especially in indolent malignancies, because our treatment options have improved so much that a lot of patients, fortunately, are doing really well for a really long period of time. On the other hand, in more aggressive malignancies like diffuse large B-cell lymphoma, it's much easier to demonstrate an overall survival advantage because of the aggressive nature of the disease, and you have more events. So, for purists, anything short of an overall survival advantage is not a good enough reason to use a therapy which potentially can have adverse events. So the idea is that you improve survival and you minimize toxicity. So if an approach checks off those two boxes, then that's a good or reasonable maintenance option. Now, some people can argue that if you keep the patient in remission longer, those patients might have more options available to them down the road in terms of cellular therapies nowadays, new clinical trials, new drugs that get approved. So there is some legitimate argument to be made for using event-free survival or progression-free survival as a surrogate for a reasonable maintenance therapy option. So this is an ongoing debate. I don't intend to resolve this in this 20-minute discussion, but that's kind of the principle of a maintenance option: limited toxicity, improving outcomes, and we will limit ourselves to that. So we'll cover 4 diseases today in the next 20 minutes or so. The first one, obviously, is the most common one, diffuse large B-cell lymphoma. And when you go to the indolent side, you have follicular mantle cell, as we all know, is such a variable disease that sometimes it's extremely aggressive and not responsive to chemotherapy. Other times it behaves very indolently. Somewhat similar is Hodgkin lymphoma. So those would be the 4 diseases that I will discuss what kind of things we can do for these diseases in the post-transplant setting. All right, so let's go back a few years, a couple of decades, and this is where most of the problems started, in my opinion. This is essentially the French effort, and this is a non-conventional non-standard induction therapy that they utilized. And this was the French version of hyper-CVAD, and nobody uses it anymore, fortunately. And this was one of the first studies that was published a long time ago that used a consolidative autologous transplant, which essentially is high-dose chemotherapy, in first complete remission. And they basically demonstrated that patients who underwent autologous stem cell transplant actually had a better outcome as compared to patients who did not or received conventional therapy. The biggest thing to remember in this particular study is that this was in the pre-rituximab era. So none of this should be relevant nowadays, and we've discovered it since then that rituximab will overcome most of these issues. So bottom line is, this was kind of the first or the initial efforts which suggested that more chemo is better, and the higher the dose, the better the outcomes are. And before the advent of targeted therapies, that seemed like a fairly reasonable approach. Now, moving on, to the Coral study, and we all know that this has kind of been the hallmark study for in the transplant world for diffuse large B-cell lymphoma. So I won't go into too much details, but essentially this was one of the first studies in the rituximab era, very large randomized controlled studies, multiple arms, in which there were maintenance options utilized after patients underwent an autologous stem cell transplantation. This is the more conventional way of doing stem cell transplantation in second remission. So patients who had chemosensitive disease were randomized to rituximab versus no rituximab. And as it turns out, that the addition of rituximab does not result in improvement in either progression-free survival or overall survival. What was interesting was that if you compare the patients who had no prior rituximab and you gave them rituximab in the maintenance setting, they did really well. But if they had prior rituximab, their outcomes were not as good. So the bottom line was that it matters if you give the patient a targeted therapy, but it doesn't really matter, or maybe there might be some benefit of doing it in the maintenance setting, but obviously we have since stopped doing that, and we do it in the upfront setting so that we can salvage more patients upfront. So another issue with this particular data set was that there was an increased risk of infectious complications, like we expect with the use of rituximab, especially now in the COVID era. That is a significant concern because it decreases your B cell function and increases the risk of sinopulmonary infections. So as a result, after the Coral study, the maintenance use of rituximab post stem cell transplantation for large cell lymphoma declined, and it is not utilized anymore. We haven't given up on that approach, though. I mean, there are lots of studies that have been done since then and are ongoing, which has demonstrated some activity and benefit in the post-transplant setting. So one of those is pidilizumab, which is again a PD-1 inhibitor. And the idea was that in the post-transplant setting, you do have an immune-rich environment where a checkpoint inhibitor can overcome that immune tolerance. And as the immune system is recovering, you can potentially reprogram the T cells and get good responses. So there was some promising early results with this study or with the use of this particular agent. Since then, it's kind of been used here and there, but not in a systematic large study. One thing that was interesting was that the effect of pidilizumab in this instance was highest or most pronounced in patients who had chemorefractory disease, who had some residual lymphoma after autologous stem cell transplantation. So the PET positive patients actually did really well, and some of these patients had a fairly long disease-free or progression-free survival, which, you know, you can argue that maybe potentially some of these patients can be cured with longer follow-up. Regardless, it's not utilized as a standard option anymore. But like I said, there's multiple efforts ongoing which are utilizing different agents to improve the outcomes in this setting. However, as it stands right now, there is no role for standard maintenance rituximab or other CD20 or antibodies in diffuse large B-cell lymphoma following an autologous stem cell transplant. I don't want to get into the specifics of when the transplant should be done because that will be covered in another discussion. But generally, transplant is done as a salvage therapy after second-line treatment. Now, that complicates the issue in the near future, possibly with the use of CAR T-cell therapy in that setting, in the second line or the maintenance or the consolidation setting. You can call it whatever you want. But as it stands right now, after a standard auto transplant, you don't need to put patients on standard maintenance treatment for large cell lymphomas. All right, so let's move on to follicular lymphoma. Again, the most common indolent lymphoma. People have tried all sorts of different approaches, purging, in vivo purging, before or at the time of cell infusion, right after cell infusion, at the time of collection. All sorts of approaches have been utilized over the years. Similarly, maintenance options have been used. This is the larger EBMT effort in which a short course of rituximab was used in the maintenance setting. So basically only 8 doses of rituximab, actually 4 doses of rituximab. So every 2 months times 4. So over 8 months, they gave 4 doses of rituximab. So much shorter than what we are typically used to using in the follicular lymphoma setting. Now that did demonstrate some improvement in progression-free survival, but there was no improvement in overall survival. And there was also a higher risk of neutropenia and infectious complications as expected, anywhere in the 10 to 20% range. And this is can be substantial, especially nowadays with the ongoing pandemic issues. Another important thing from this studies and multiple other studies that was done is that the in vivo purging with rituximab or with similar approaches, people have tried different things to purge the product of the lymphoma cells, and that has no effect on the eventual outcome. So similar to other data with rituximab in the follicular lymphoma space, there is some evidence of improvement in progression-free survival and event-free survival, but not overall survival. So can we utilize this treatment? I can say fairly comfortably that there is no role for standard maintenance in follicular lymphoma. If you want to do maintenance treatment for follicular lymphoma, ideally it should be done as part of a clinical trial. And again, cellular CAR T cell therapy is available for these low-grade lymphomas too. There are also a lot of really exciting developments in the bispecific areas and also targeted therapies. So there's so many very different options for follicular lymphoma management that we are not utilizing autologous transplant as much as we used to. I think there's very few patients who would actually have the true really POD24 follicular lymphoma who would ordinarily go to autologous stem cell transplantation. I think most patients will be managed very easily with various targeted therapies for a very long period of time. So, and if they don't, then those are usually the people who have transformation into large cell lymphoma. But as it stands right now, the recommendation or the official guideline would be that maintenance treatment should not be utilized for autologous stem cell transplantations in patients with follicular lymphoma. All right, so let's talk about mantle cell lymphoma, the famous LYSA trial. You guys all know about it. I won't get into too much details, but this is one of those rare instances where actually maintenance did improve survival. Categorically, I think there was significant improvement in progression-free survival and overall survival. Slightly different maintenance regimen in this particular trial. Maintenance was done a little bit for a longer period of time, so over 3 years, once every 2 months for 18 doses. So a 3-year treatment following an autologous stem cell transplantation. Couple of caveats with this. The standard reduction used was RDHAP. Most of us don't use that. We use some combination of bendamustine, rituximab with cytarabine, or the Nordic regimens, or whatever you have. But a lot of variation happens in the choice of initial therapy. But if you do a transplant in patients with mantle cell lymphoma, you can make an argument that 3 years of maintenance rituximab might result in improvement in overall survival. Now, there's another small little caveat with this particular trial. This was basically for patients who were 18 to 65 years of age, so slightly younger patients. Now, historically, the cutoff used to be 60, 65, maybe up to 70 for autologous stem cell transplantation. And I know from what we do personally that that is such a relative number, and we don't really consider that too much as long as the patient has a good performance status. I think we can do a transplant safely and get patients safely through it all the way up to 80 years of age. So categorically, just the age as a number is not necessarily a contraindication anymore to proceeding with transplant. Having said that, we also know that the use of rituximab for any length of time, especially in patients above 70, results in a significantly higher incidence of infectious complications, which is what was seen in this trial. So as a result, if you want to use rituximab, it has to be, those patients need to be monitored very closely. But after the LYSA trial, maintenance rituximab became kind of the standard approach in patients with mantle cell lymphoma who were undergoing autologous stem cell transplant. This is the CLGB 50403 studies in which they've utilized bortezomib maintenance in two different regimens. One was a shorter version, one was a slightly longer version, 10 cycles versus 4 cycles. So you can call it consolidation versus maintenance. And essentially, these patients were randomized or to a higher dose or consolidation versus maintenance. So it wasn't really a control arm to see which one was better. So between the two arms, there was no difference. It was exactly the same in terms of their outcomes. The issue with the use of bortezomib was that it was, so a lot of patients withdrew with treatment because of toxicity, cytopenias, neurotoxicity was an issue. So this wasn't a very popular approach. However, when they went back and looked at the CLGB 59909, which was a fairly similar cohort, similarly treated mantle cell lymphoma patients, they did find that the addition of Velcade or bortezomib actually did improve outcomes as compared to a fairly similar cohort of patients in a previous study. So some argument can be made that potentially you can improve progression-free survival, but I think the toxicity of the drug makes it a little tricky, especially in the post-transplant setting when patients are also not feeling too good. So as it stands right now, I think it's safe to say that rituximab every 2 months for 3 years should be considered as standard of care therapy for younger patients who are undergoing an autologous stem cell transplantation. For mantle cell lymphoma, bortezomib potentially may have some activity. The Nordic group has studied this as a preemptive strategy in which they've utilized rituximab for patients who become MRD positive without clinical evidence of disease, and it seems to be effective even in that setting. So you can argue that I might save rituximab for later, monitor patients closely with PCRs for 11-14, and then institute rituximab at the time of having MRD positive disease. Now, we also have CAR T cells therapy approved for mantle cell lymphoma, which adds another wrench in this situation. So I think the jury is out, but as it stands right now, for the patients who do undergo autologous stem cell transplantation, if it wasn't for the COVID pandemic, I would be very comfortable in giving them 3 years of rituximab therapy. Finally, we'll talk about Hodgkin lymphoma. Multiple studies have been done over the years with various different approaches. The famous ones, again, only are the interferon trials, the IL-2 trials, panabinostat efforts. There's so many different things that have been tried, and all of them did not show any significant improvement in outcomes as compared to the comparator arm. And historically, they were also associated with a lot of toxicity. So it never really took on. However, we are all familiar with the ATHERA trial. May not be even relevant nowadays, but basically in the select patient who had primary refractory disease or short initial remission or had extranodal disease without prior brentuximab, in patients who did not receive any prior brentuximab, 16 doses, roughly a year of brentuximab therapy once every 3 weeks actually did result in improvement in progression-free survival, not overall survival. Now, hardly anybody uses that as the first time that the patient is exposed to brentuximab. Most patients will get brentuximab either up front as BV-AVD, which has become our standard option nowadays, off trial, and the few patients who will relapse with Hodgkin lymphoma after BV-AVD will get checkpoint inhibitor or some other type of therapy. So the vast majority of patients have seen prior brentuximab. So the argument now is that adding brentuximab as a maintenance option post-auto transplant in patients who've already been exposed to this may not have that much of a bang. So again, it's up for debate, but that was our standard of care when we were using ABVD and ICE, for example, without brentuximab in the past. So can be important options, but checkpoint inhibitors and brentuximab up front has really changed the way we manage this disease. But I think it's kind of tricky, but I think for the most part, very limited role for a maintenance option in Hodgkin lymphoma. So just to put it all together, I have the no column for large cell lymphoma, follicular, definitely CLL, I'll just throw it in there. No role for maintenance in these settings. Not that we do autologous transplant for that anymore. Mantle cell lymphoma has definitely a yes, and then the Hodgkin, I put it in the maybe, depending on the way you're practicing. There are multiple trials are going on in various histologies, which might potentially change the way we manage these diseases. And obviously, CAR T cell therapy is available for pretty much every indication, and that adds another layer of complexity. So for Pakistan, what could be relevant? I guess one of the things that's important to consider would be the cost and also the risk of infectious complications. I think that requires a discussion with the patient, the resources available to us, and whether that is necessarily the right thing to do in possibly a resource limited setting that some of our patients might have, and they may not have access to those therapies. So with that, I will wrap up, and I look forward to a good discussion. Thank you.
Thank you so much, Dr. Farrukh, for that presentation. You have very aptly described to use, or rather when not to use, rituximab post-transplant. We know that you're online, and we're also looking forward to a very healthy discussion after the talks. We're halfway through the session, and our next speaker for the session is General Dr. Qamar Nisa Ch. She's a professor of clinical hematology and bone marrow transplant physician, and she is also the director of Armed Forces Bone Marrow Transplant Center and National Institute of Blood and Marrow Transplant. Exactly like her many publications in national and international journals, her special interest is in bone marrow failures and aplastic anemia. And today she will talk to us and enlighten us on the same topic, which is transplant outcomes in high-risk aplastic anemia.
Assalamu alaikum, ladies and gentlemen. Firstly, many congratulations to the organizers for organizing this all-virtual HemeCon. And thank you so very much for inviting me to be a part of it. So I'll be talking about allogeneic bone marrow transplantation for aplastic anemia. And incidentally, it's 50 years since the first transplants were done for aplasia. So the diagnosis of aplastic anemia is fairly straightforward. There's a paucity of cells both in the peripheral blood and in the bone marrow without any other abnormality. So the general consensus is that this is a fairly common disease in our part of the world, but there is no local registry. So we collected data for 2017, and there were a total of 651 new cases of aplastic anemia that year. So based on the population, that would be 3.5 new cases per year per million population. I feel that is just the tip of the iceberg. AFBMTC has a registered cohort of nearly 2,000 cases, and we see about 150 new cases every year in AFBMTC. So these are the international data for transplants from the EBMT and from CIBMTR, and you can see that bone marrow failure and aplastic anemia are only a very small fraction of the cases that undergo transplant. On the other hand, these are our data, and this very large orange segment at the bottom, accounting for 1/3 of all cases, is for aplastic anemia, so a major indication for us. Now, transplant has revolutionized the treatment of aplastic anemia, and this is the treatment of choice for younger patients who have an HLA identical sibling donor, both for children and adults. Patients who do not have a matched sibling donor can be given immunosuppressive therapy with forced ATG and cyclosporin, and failing which they can go on to an unrelated donor transplant. Haploidentical transplant is considered to be an experimental treatment for severe or very severe aplastic anemia. So talking about immunosuppressive therapy, I'd like to go over the results of the RACE trial. These came out only last month, and this study was done. This is a randomized trial that was done to compare horse ATG plus cyclosporin with standard immunosuppression plus L-Trombobag. And this study was done by the EBMT. It's a multi-center trial. And what they did essentially was to give one set of patients, about 101 patients, the standard immunosuppression with horse ATG plus cyclosporin. In the second group, Group B, they gave an additional drug that was L-Trombobag at 150 milligram per day. And what they were able to show that the patients who received the additional L-Trombobag, that is Group B, had better responses at 3 and 6 months, and that these responses occurred earlier. And the overall survival was impressive at 97% at a median follow-up of 2 years. But when you look at the complete responses, they were quite small, 22% at 3 months, 32% at 6 months. And the relapses were particularly troublesome, 57% at 6 months. So they extended cyclosporin to be given for 2 years to bring down the relapse rate. The median time to respond was 3 months for the L-Trombobag group. And the event-free survival was 46% for the L-Trombobag group and 34% for the standard immunosuppression. And here you can see this large blue area of patients in both groups who did not respond. Children who were not included in this particular trial did not benefit from L-Trombobag addition to the standard immunosuppressive therapy. In fact, they have rather good results with immunosuppression role. Another problem that was reported in this trial is the evolution to an abnormal karyotype, which was seen in about 30% of patients at 2 years. And clonality, including chromosome 7 abnormalities, which are quite high risk, were seen mostly within the first 6 months of L-Trombobag initiation. So our problems with respect to immunosuppressive therapy are that horse ATG is not always available. Rabbit ATG, which is available, is less effective. About 30% patients respond. And because it is so very immunosuppressive, they have a much higher risk of infections. And especially the cost of the 3-drug combination would come to 2.5 to 3 million. And this is when we have cost sharing by Novartis, so the patients pay about 50% of the price for L-Trombobag. So not an easy option at the end of the day. So I would tend to agree with the recommendations put forward by Rainer Staub and colleagues, and he's a pioneer in bone marrow transplant for severe aplastic anemia patients. The first treatment priority is HLA identical sibling bone marrow transplant, followed by a 10x10 unrelated donor BMT, and this option is of course not available with us. And the third is HLA haploidentical donor family member bone marrow transplant using PT-SAN. Immunosuppressive therapy with the triplet is recommended only for patients who are not a candidate for bone marrow transplant due to comorbids or advanced age. So coming to our own unique situation, we are lucky in terms of demographics. Our patient population is generally younger. The median age for our population group is 20 years, and 87% of our patients are younger than 40 years of age. The rest of the picture is not as rosy. There are problems with access to care, inadequate healthcare structure and referral system. Our transfusion services are quite sketchy and basic. There is an issue with the cost and availability of specific treatments, and just like we talked about horse ATG, and there's a shortage of hematology and transplant setups, and also a shortage of trained human resource. So these are major problems, and they all lead to multiple issues. There are delays in diagnosis and referral. Patients are exposed to unnecessary treatments, including high-dose steroids, They get repeated transfusions before they get to transplant. So there's this high risk of under-immunization. They're exposed to transfusion-transmitted infections. And we have the experience from thalassemia, where 60 to 80% of patients are positive for hepatitis viruses, and now HIV as well is a common infection. So these patients can have repeated infections, iron overload, and the list can go on and on. And the end result is that these patients are at a high risk for graft failure, GVHD, infections, and a higher transplant-related mortality. So an overall, a very high risk group for transplant. So the questions that I'd like to ask and to answer during the rest of the presentation are, can we quantitate or gauge the effect of these risk factors on transplant? And can we then adopt a risk-adapted approach? What is the best conditioning regimen for these patients? Do we need to optimize the GVHD prophylaxis? Is haploidentical transplant a feasible option for our patients? And what is the effect of an active infection or a focus of infection on transplant outcome? And when all is said and done, have we managed to improve transplant outcomes over time? So let's look at each of these one by one. So these are our data up to December 2021, 1,264 transplants, 1,100 allogeneic, out of which 46 are haploidentical, and 414 transplants for aplastic anemia. Looking at international data and our own patients, we were able to identify these factors which define a particularly high risk group of aplastic anemia patients. So these are recipient age of 20 years or more, time from diagnosis to transplant of 3 months, red cell transfusions, and random donor platelet transfusions, more than 20 red cell, more than 50 platelets, and second bone marrow transplant after the failure of a first transplant. And this is a multivariate analysis of all of these factors affecting overall survival in these patients. And you can see that all of these factors come out to have a significant p-value, and they're statistically significant in the analysis. So this is a large cohort that we looked at, 304 patients. The ones in blue are those patients who have 2 or fewer risk factors. And the ones shown here in green are the ones who have more than 2 risk factors. And here you can see there's a significant difference in the outcome in terms of overall survival and the disease-free survival. So coming to the conditioning regimen, we have published this comparison between the standard cyclophosphamide conditioning with fludarabine-based conditioning. We started using fludarabine somewhere in the later part of 2001. And this is a retrospective analysis that looked at 192 high-risk patients, 79 of whom received cyclophosphamide-based standard conditioning regimen, and 113 received fludarabine-based conditioning. And these are the results. The group here in blue is patients who received fludarabine-based conditioning, and they did better in terms of overall survival, disease-free survival, and GVHD and relapse-free survival from patients who received cyclophosphamide-based conditioning. And you can see that this is particularly significant here and in terms of disease-free survival. And when we looked at patients, the number of risk factors they had, patients who had 2 or fewer risk factors did equally well if they received fludarabine-based conditioning or cyclophosphamide-based conditioning. But for patients who had more than 2 risk factors, cyclophosphamide did not lead to good results, and patients who received fludarabine-based conditioning did particularly well, both in terms of the overall survival and the disease-free survival. So looking at the entire cohort of patients who received fludarabine-based conditioning, this is an analysis of 147 high-risk patients with a median age of 20 years. And these are the different conditioning regimens that were given, and the doses are slightly variable, but I'd like to draw your attention to this particular regimen in which we gave fludarabine 120, cyclophosphamide 300 milligram per meter square with ATG 20 milligram per kg. And this is the regimen which has been recommended by EBMT for high-risk patients and was being used in the UK as well. But for our patients, we saw that patients who received this regimen did particularly poorly, especially in terms of disease-free survival. We had a lot of patients who had primary or secondary graft rejection. So clearly, cyclophosphamide 300 milligram was effective, insufficient for conditioning. So coming to graft versus host disease prophylaxis, and this analysis looked at 106 patients, the great majority of whom had received a bone marrow harvest, but 32% of the patients received PBSC in addition to BMH to make up the dose. We did not have a lot of GVHD, 3.8% acute, 7.5% chronic GVHD in patients who received bone marrow. This was much lower, 1.4% acute and 4.7% chronic. So we do not have a lot of GVHD. But the addition of methotrexate did not improve survival. In fact, you can see that this group that received CSA plus methotrexate, which is a standard recommendation, and these patients had a lower overall survival, disease-free survival, and in fact, even a GVHD and relapse-free survival, and the p-value here is significant. So methotrexate did not add any benefit to the overall survival or the disease-free survival. So coming to the issue of active infection, we had to take 28 patients to transplant who had an ongoing sepsis or an active focus. And when we look at the results, we see that these patients did particularly poorly, 15% overall survival and 13.5% disease-free survival. So lastly, we come to haploidentical transplant, and this is the conditioning regimen. This has been registered at clinicaltrials.gov as a clinical trial. And the conditioning is fludarabine plus cyclophosphamide and ATG plus busulfan. It's a TBI-free regimen. The GVHD prophylaxis is with cyclophosphamide given on days 3 to 5 post stem cell dose, and MMF given through days 5 to 35, cyclosporin given through days 5 to 365. And we've done 20 transplants using this regimen. The ages are 1 to 36 with a median age of 18, and the male to female ratio of our patients is 9 to 11. We had 30% primary graft rejection. That is 6 patients and 1 secondary graft rejection. This was due to CMV reactivation. We did not see any acute graft versus host disease. Chronic graft versus host disease was seen in 2 patients. Both had skin GVHD, 1 limited, 1 extensive, and we had 11 deaths, 55%. So the overall survival and the disease-free survival both were 45%. Coming to the mortality, 6 patients died because they had primary graft failure, 1 with secondary graft failure. 2 patients did not get to engraftment and died before that due to sepsis. So really, this is not TRM. And 1 patient had COVID and died, and 1 patient had an accidental death. So 2 completely unrelated deaths, but 7 graft failures. And this is the result of 46 patients who underwent haploidentical transplant. We had reasonably good results for acute leukemia. Aplasia, 52% overall survival. And I think that is reasonable given that we've not had so much experience with haploidentical transplant in aplasia. And secondly, also because our patients are so very high risk by the time that they get to a transplant. So have our results improved over time? So Here you can see data broken down over different time periods. So in green here, these are patients who underwent transplant from 2001 to 2008. In blue, from 2009 to 2014. And the yellow line here, which is a little hard to see, from 2015 to 2019. So our most recent data show an overall survival of 87.3% and a disease-free survival of 84% for patients, a majority of whom are high risk. And these data are comparable to data from CIBMTR. These are summary slides for younger patients and for adults for aplastic anemia, and you can see that the data are comparable. So in conclusion, our results of transplant in high-risk aplastic anemia are comparable to international data. We recommend fludarabine-based conditioning in high-risk aplastic anemia patients. Cyclophosphamide 300 milligram per meter square is insufficient for sustained engraftment and should probably not be used. Cyclosporin alone is sufficient as GVHD prophylaxis in patients who are receiving fludarabine-based conditioning, and haploidentical bone marrow transplant is a viable option for our patients. So thank you so very much for your attention. I'd be very happy to answer any questions that you may have during the panel discussion.
Thank you so much, Dr. Chaudhary, for that review. And you've clearly shown that addition of fludarabine really improved the overall survival in these high-risk aplastic anemia patients. And we're surely going to take that up in the Q&A session after our last talk, which is by Dr. Mohammad Ayaz Mir. Dr. Ayaz Mir is a clinical chief of bone marrow transplant unit at Shifa International Hospital, Islamabad. Having graduated from King Edward Medical College, Lahore, he did his residency in medicine and fellowship in hematology at State University, New York. He completed his fellowship in bone marrow transplant from Mayo Clinic. Dr. Ayaz has many publications to his credit in peer-reviewed national and international journals. And today, Dr. Mir is going to talk on a topic extremely relevant to the transplants logistics in our country, that is, issues and potential solutions of stem cell transplant program in developing countries.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Mohammad Ayaz Mir and I direct the bone marrow and stem cell transplant program at Shifa International Hospital. I'll be talking about problems and solutions for programs in developing countries. When it comes to the definition of developing countries, there's no consensus, but in general, by most definitions, all countries except Japan, South Korea, Australia, New Zealand, Canada, America, and Western Europe fall into developing countries. China is actually rumored to leave that list and become a developed country by next year. When we think about issues in transplant in developing countries, the first and foremost thing that comes to mind is there will be a lot of whining about cost and how these countries are poor and they don't have the money to do this expensive procedure, and that's partly true, but that is not the whole truth. There is more than cost involved in starting and maintaining stem cell programs in the developing world. And one of them is this: you don't have, even where you have money, like a lot of countries in the Middle East, you do not have the human resource, the trained transplant team to carry out these ventures. A lot of trained staff from these regions has gone to West and settled there, where life is more lucrative and programs are more developed. This is a graph from NEJM that I think is from 2011. Along the y-axis, you see the global disease burden, and along the x-axis, you see the global health workforce. So Southeast Asia has the highest global disease burden, but you see the highest density of healthcare force in Americas. So that is a contrast. That is a paradox in the healthcare. Despite these challenges, a lot of transplant programs have popped up into the developing world. This is a world map showing transplant centers in many countries in Africa, Asia, Far East, and Middle East and Latin America. That tells you that people have started these programs despite the challenges. We'll take a case study of Ghana, for example, a sub-Saharan African country where sickle cell disease makes up majority of burden of diseases that need to be transplanted. And one of our esteemed colleagues, Dr. Faulkner, who has worked with Cure to Children for decades and has helped transplant many transplant programs in Asia, including ours in Shifa. First 5 transplants with thalassemia were done with his help in India, Bangalore, and in other places. He also tried starting a program in Ghana, and that was not very successful because of local circumstances, because of challenges of sending tests outside the country and lack of infrastructure. And the cost of transplant went up to almost twice that in India when he tried to establish a program in Ghana. Here's another country in Africa, Algeria in Northern Africa, which is also a country in Saharan Africa. And here, successful transplant program, actually 2 of them were built because 90% of the population of the 40 million is insured and is under universal healthcare coverage. There are 2 BMT centers that have done about 300 or more transplants, half auto, half allo. Although 98% of these are adults and the pediatric transplant program is not very robust. They do not have -80 freezers, but they still carried on auto and allo. So when we talked about developing world, there's a lot of diversity, there's a spectrum. And even within a country, there's a spectrum. For example, in countries like Pakistan, there is government programs that have constraints and a lot of red tape and less funding, but still some of them have carried out successful transplant programs. There's private for-profit hospitals like ours, which provide good service but are costly. There's military programs. Actually, largest program in Pakistan is Armed Forces program, which has carried out more than 1,000 transplants, mostly for aplastic anemia and thalassemia, and has done a superb job of collaborating in research as well. There's academic institutes where focus is on education and training, and these include places like Awan. There is places that focus on medical tourism. A lot of these centers are located in India that have made money out of transplanting people from other developing countries. And then there is a few philanthropic centers which are transplanting people for free, a small but considerable number, and they're doing a great job. This is a paper by Faulkner and colleagues, and he talks about setting up and sustaining programs in middle-income countries. And this is what they define as the minimum workforce needed. For a 4-bed unit, you need 2 transplant physicians and about 10 nurses along with logistic support. The cost in this setup is roughly $10,000 to $12,000. This is extrapolated from India, similar in our centers, which is roughly 1/10 of the cost you need in Europe or US to do a transplant. This is a paper by my teacher and mentor, Dr. Shahrukh Hashmi and his colleagues, and they defined the cost and quality issues in transplant, and they divided into level 1, 2, and 3. And for a level 1 transplant center, you do not need HEPA filters, you do not need ICU or sophisticated machinery, and you can just start from very basics. So I'll try and talk these issues and their solutions in 3 terms: in terms of the transplanter, in terms of the trainee, if you are lucky enough to have one or more, and in terms of patient's perspective. So from a transplanter's perspective, you need 6 things to do a transplant: the apheresis lab, a superb blood bank, HLA typing service, local or outsourced stem cell lab for preserving and manipulating cells. You need superb nursing, and you need excellent pharmacy support. One of the things when you start a transplant program is you don't want to be selling Ferraris where tractors are needed. You want to know your local value and see what the need of that country is. If the need is thalassemia or sickle cell or hemoglobinopathy or aplastic anemia, and you are selling exotic transplants for diseases like amyloid, it's probably not going to fly. Once you have built, the next target is to sustain and make it financially viable and attractive for government and other funding. Then you expand and focus on quality. And then finally, your goal is to collaborate with the sister research centers and transplant centers in the region and beyond to sort of get on the circuit and to progress to newer technologies. There's a lot of literature on what is needed to start a transplant program by the people I mentioned before. I would go into what is not needed. These are things you do not need to start a transplant program. You don't need apheresis machines. You could do bone marrow transplants without them. You don't need HEPA filtered rooms to start with. They can be costly. Their maintenance is costly. Their cassettes are costly. High resolution HLA is not needed if what most of you are doing is matched sibling programs. Chimerism on site is not needed. CD34 counts you can let go if you're doing bone marrow transplants. There's pretty good data on TNC, total nucleated cell count, to be sufficient for good transplant outcomes. Marrow harvest systems are expensive with different filters and pathways and sophisticated. We use simple blood bags to collect our marrows. Liquid nitrogen and minus 80-degree freezers have a limited utility in the developing countries. Even in developed countries, they are, the number of times you go back to your vapor nitrogen and get stem cells back to do a second transplant is probably 1 to 2% of all myelomas and other transplants. Total body radiation is not necessary. Most of the haplo protocols do use TBI, but there's protocols like JESWAL that we use to start our haplo program in 2016 that do not need TBI. We now have TBI and have used mostly flu-site TBI for last year or so. Graft manipulation with CD34 positive selection or T cell depletion has never been shown to really make a big mark on survival and is not needed. The other major challenge you face is drugs. A lot of these drugs are not manufactured in developing countries, with exceptions like India and now recently Bangladesh and Sri Lanka. China is, of course, years ahead. Now we are starting to manufacture some targeted agents. A company in Pakistan recently started manufacturing imatinib and sunitinib, which is great. Antifungals are a huge issue. We do not have any dulafungin. Caspofungin is available but expensive. Liposomal amphotericin is expensive. I have occasionally used isavuconazole for mucor, but very costly. Antibiotic resistance in these developing regions because of antibiotics being available over the counter is a huge issue. Number one killer in our transplant program is MDR E. coli. Antivirals are available in terms of common valganciclovir and ganciclovir, but luckily resistance for CMV is not common in this part of the world at least, and we have rarely used foscarnet or cidofovir, and letermovir would be ideal because it does not drop counts but is not available. We do not have exotic chemotherapies like thiotepa and triosulfan, but most of the other agents are available. So local and regional production is the key. You cannot sustain a cost-effective transplant programs if you are importing in US dollar that is becoming beyond reach by the day. The quality standards, you want to go to FACT and JCIE. I think most of the programs in developing countries will not be able to qualify the strict standards these societies maintain. Association of Advancement of Blood and Bioproducts, AABB certification will be separately needed for your blood bank. We have local authorities like HOTA, which provide accreditation for transplants in the country. Reporting is encouraged to CABMTR and EBMT, but unfortunately the forms are complex and need some manpower to do that constantly. I think we should follow the KISS principle, and the initial form should be really simple to enroll the centers and make sure every single transplant that is done is accounted for, and we can later go to depth. So this is the BMT staircase. This is what you do when you start a transplant center. You're supposed to start with autologous, matched sibling, then haplo, then MUTS, then COD, and then CAR T therapy. But in reality, matched sibling is probably easier to do than autologous, and many programs go to autologous later and start with a matched sibling program, which is technically easier. What are trainees looking for? I think trainees need standardized broad-based training, especially in peds. A lot of pediatric diseases like immune disorders and ALL and hemoglobinopathies and things like Blackfen, Diamond, you'll only see in the pediatric unit. You need to have sufficient volume. Most transplant programs in US that have a fellowship do more than 500 transplants a year, some do more than 1,000. You need a strong hemonc base for referral and training. And I believe many fellowships, your fellow spending 3 months at MD Anderson or Mayo Clinic or in a good center in UK or going to China, which is currently leading in CAR-T trials in the world, makes a lot of difference. And I believe there should be exchange fellowships. There are things that West can learn from East. An example of that is haplo programs in China due to their unique social and financial circumstances. And then I think it's time that in the developing countries, we start training our labor force in fields like synthetic biology and gene therapy and basic research, which will eventually advance the field. Research is time consuming, costly, and even contributing to research is costly for us. You present a poster in blood, in ASH or ASTCT, you need to have the membership and spend money. And that opens the back door for things like Sci-Hub for pirating articles that you need. This is an example of things that we can learn from, the West can learn from East. This is a unique haplo program in Thailand by Anurathapan and colleagues that boasts a 96% overall survival at 3 years. I would be happy to send my fellow for a month or two there to learn this. This is Dr. Raheel Iftikhar, a dear friend and colleague, his and General Parvez database for aplastic anemia, for which they treat a huge number and have developed a considerable expertise. Unfortunately, again, this is not available to us for review. They want me to pay $32 or pay 11,000 euros to get the subscription. That's more than cost of my transplant. So this needs to be remedied. This literature should be available to us for free. What are patients looking for? Patients in our part of the world, their number one concern remains cost. Remember, these are the people who are facing these diseases head on. They're fighting the disease, they're fighting the finances, they're fighting the social circumstance. So cost and then the added cost. When a patient sells something and gets a transplant, and 2 months later they have a steroid refractory graft versus host disease, they simply are unable to collect that amount, a similar amount to fight that monster. And I have had people lama from ICU. Then you need education materials in local languages. That is something, there's a lot of literature in Google and English and other languages, but in your local language, you have to yourself make brochures, those 2-minute YouTube videos about graft versus host disease, HLA typing, and things like that. There is people want outcome comparisons to West. They want to know how successful your program is compared to one in US. And in our part of the world, a lot of patients have concerns about a job. Many of them are breadwinners. There is no disability insurance. People want to know when they can go back to their job after transplant. There's fertility issues for young females, especially there's cosmesis issues that need to be discussed before and after transplant. So this is how transplant programs in West are looking. There is increasing use of MUDs. Mashed unrelated transplants are no doubt rising across Atlantic. And that is why more than 50 countries in the world have donor registries. This is not the case in most of the developing world, with exceptions like India has 4 donor registries, Iran has a registry, but some countries like Pakistan do not have a registry. The cost of borrowing cells from outside the country is prohibitive. It takes about $40,000 to buy cells if you do not have a registry of your own. You need high resolution typing if you're doing MUDs. And in our setup, since there's a lot of consanguinity, about 90 to 95% patients will find a fully matched sibling or a haplo donor without a DSA. But for that 5% or so, we need to have registries. In last couple of years, at least my and I'm sure other colleagues' practice has been modified a lot by telemedicine due to COVID. I've had patients who I have not seen in months after transplant because they email me their labs and they visit me online through the software to tell me how they are doing. And except for putting my stethoscope and touching them, I think it works well, and that is changing the transplant landscape. People have done unique things in developing world. Our friend Bishesh Podyal single-handedly started a transplant program in Nepal. He's rumored to work for a salary of like $400 a month and has done a superb job putting his country on the map. In Pakistan, in Gambit, a transplant program, a free transplant program has been started in Sindh, And this program also has done more than 500 liver transplants and is a very unique institute currently under the leadership of Dr. Parvez. There's more and more third-party payers coming in this part of the world, which is a good thing, I guess. Government recently has issued health cards, and they are now being made eligible to participate in the transplant programs, which will offset a large part of the cost. In Pakistan, transplant was started by Dr. Tahir Shamsi, recently deceased dear colleague, who in 1990s. And from that one transplant, last year we did more than 420 transplants across 11 centers in Pakistan, although 2/3 of these were still done in and around the capital area by FDMTC and Shafa. So this is the summary slide. I think the cost issue can be tackled through local manufacturing of drugs. We need to improvise like use of transfusion bags for collecting marrow. We need to build a registry. We need to curb the black market, which unfortunately is a large part of our transplant programs right now. And we need universal coverage. We need to make those social media videos for awareness. We need to start online support groups. We are working on them. We need to make people be aware of the stem cell scans for things like muscular dystrophy and cerebral palsy. And we need to train our fellows on a broad basis. And we need to move to new fields like CAR-T, which unfortunately will not be available in our part of the world anytime soon due to market forces. Research, EMR is pivotal to collect and distribute data. We need to collaborate more, and our fellows need to publish more. We need to have local guidelines like our friends recently did. Dr. Adil spearheaded the effort to do local guidelines for diffuse large B-cell lymphoma for Pakistan. We need more of that. There's some local regulation by authorities like CPSP and HOTA, which need to have adequate hematology representation. And quality is an issue in future, not right now, but eventually we'll need to get to the JCI and EBMT standards. I thank you very much for your time.
Thank you very much, Dr. Ayaz, for that very realistic approach to the stem cell transplant program in developing countries, especially Pakistan. I'm going to now hand over the floor to General Parvez, chair of the session, to take the discussion forward.
Thanks, Natasha. Excellent and elaborate talk by all the speakers. They are all, I would say, have got vast experience and are authority in their respective fields. I suppose Dr. Bipin is online. He is not around.
No, sir, he's not. He's not on.
He is not. So, Dr. Farrukh. Is Dr.
जी सर, अस्सलाम वालेकुम.
अस्सलाम वालेकुम. कैसे हैं?
अल्हम्दुलिल्लाह. सुबह इतनी पता नहीं, लेकिन ठीक है, अल्लाह का शुक्र.
Thank you very much for taking time at a very odd hours. There is just one small query that in a patient with mantle cell lymphoma, in the current scenario of the COVID-19 and exposing the individual after the rituximab, can we monitor the disease with PET scans and by giving something less immunosuppressive like lenalidomide or ibrutinib?
Absolutely, and thank you. This is always a pleasure being here, and it's always nice to meet you guys virtually, hopefully soon in person. So I agree with you. I think I also mentioned during the discussion that the COVID issue has changed at least our practice significantly, and we are trying to come up with any excuse not to give maintenance for any disease, especially if it's a rituximab or any immunosuppressive therapy. So in the last couple of years, I have not given maintenance rituximab routinely. I don't use ibrutinib as maintenance. And if you're talking specifically about a post-transplant setting, I will monitor them by either a flow-based assay or a PCR-based for 1114 because it's pretty sensitive. I typically don't do scans because it won't necessarily change my management unless the patient is symptomatic. So routinely, I have not used maintenance treatment for mantle cell lymphoma. Obviously, if they have active disease that needs treatment, then by all means, acalabrutinib or zanubrutinib would be my preferred options. We've kind of moved away from ibrutinib because of the cardiovascular toxicities, and lenalidomide is another option, reasonable. But before then, I think almost all of us are going to CAR T cell therapy. And the problem right now that we are facing is that, at least in the US, the approval for CAR T cell therapy doesn't specify if the patient is not a transplant candidate or if they've failed a transplant. So you can make an argument that in the second line treatment, you can potentially use CAR T cell therapy, which I haven't started doing it because I still feel that a lot of those patients can be salvaged with an auto transplant, and they maintain a very good remission for a very long period of time. I am primarily using CAR T cell therapy for the high risk blastic variants, or if they have 17p deletion. In those patients, I would prefer to go for a CAR T over a transplant.
Thank you very much. Qamar is here. Qamar?
Yes.
There is
Dr.
a
Umar, you're on
small,
mute.
Qamar, there is a small observation that you said the GVID prophylaxis, the methotrexate would cause more graft rejection. I think it is an option for a patient who has received PBSC as a source of stem cell because the data that VMCC data in which those patients that received methotrexate, this was the cohort that received the low dose cyclophosphamide. They received 300 milligram per meter square cyclophosphamide dose. And these are the patients who also received post-transplant methotrexate as GVID prophylaxis. So maybe this is one of the confounding factors, that is low dose Psy, that has led to the more graft rejection instead of methotrexate. That's just a brief comment on the role of methotrexate for graft rejection post-transplant. And very nice presentation by Dr. Ayaz Mir. Nicely elaborated all the issues that we face here. But I've got just one comment, that you have to draw a balance between the quality and cost, because there at the one end of the spectrum you have got high quality JC accreditation, FACT JC accreditation, and the laminar airflow and HEPA filters, all that setup. At the other end of the spectrum, if you forego all these quality measures, maybe you have to pay the cost of for not having the quality equipment. For example, if you get one case of invasive aspergillosis due to lack of the HEPA filter, you may have to bear the cost of treating that invasive aspergillosis that may exceed the cost of HEPA filter. So we have to we have to be in the middle, not too high quality and not too low quality. That is the best way, in which case you do not have to spend for not having the quality. So that is the best way around, in my opinion. Thank you very much. I hand over the mic to Natasha for further facilitation.
Yeah, in fact, General Parvez has already alluded to what when this talk was being delivered, in fact, and I observed that we are all cost conscious, and obviously living in Pakistan, you have to be cost conscious, but not to the extent that then you have to you regret saving the cost. For example, having an apheresis machine, I think is a must. What would you do when you need a peripheral blood stem cell over doing a bone marrow, basically? And besides, you use the apheresis machine for so many other things like getting platelet apheresis for your patient, but you glucopheresis, etc. So I think that is a must. CD34 count, yes. As a center, if not every center needs to have it, you can send the samples to the labs which are doing it. But I think you can't publish your results nowadays without doing a CD34 count, for example, and so is for a number of other things. So I agree with, and I fully agree with you that in a cost constraint setting, we have to be, you have to consider cost all, but not basically at the cost of losing quality at times.
Thank you, Dr. Salman. So yes, we have a, sure, please go ahead.
Yes, there was this point that was raised by Jennifer, and I do agree. The data that I did show was, it's not a randomized kind of trial. It's not. It's retrospective data, and I think a lot of the effect of what we would perceive to be the adverse effect of methotrexate would have to do with the conditioning regimens. And yes, that cohort of patients who received the lower dose cyclophosphamide was part of the this data set as well. So yeah, that might be one of the reasons. But of course, there's been a multivariate analysis on these data, this particular data set, and this came out to be a significant factor.
Thank you, Dr. Qamar Nisa. So there are a couple of questions for speakers and the panelists. And Dr. Farrukh, I'm going to start off with you. In your experience at your center in using maintenance rituximab for mantle cell lymphoma, how big nasty infections have you come across? And have they been treated well, or have there been a mortality secondary to those opportunistic infections post-transplant? Your experience.
A great question. The biggest problems that we have seen has been sinopulmonary infections, so pneumonias. That's been my biggest issue with rituximab. I have fortunately not had aspergillus or really bad opportunistic infection. And I'm talking pre-COVID. Post-COVID, we've seen obviously mostly COVID-related issues. I do use acyclovir and Bactrim on all our patients, and if they cannot take Bactrim for whatever reason, we use pentamidine. So I don't use maintenance rituximab without acyclovir and Bactrim, and maybe that's why we don't see a whole lot of infections, but we do see mostly sinopulmonary issues.
Thank you, Dr. Farrukh. My next question is from Dr. Tariq Satti. Sir, how has your experience been with using sorafenib post-transplant in acute myeloid leukemia?
Bismillahirrahmanirrahim. Thank you very much. Actually, two or three cases I still remember. We have used sorafenib. One of the patient when I was in Armed Forces Bone Marrow Transplant Center, in which the post-transplant we have sorafenib was given, although she relapsed and she had a second transplant from again and so on and so forth. But the two cases over here, they are still they are FLT3 positive, and both are going well. And I've started with the sorafenib. One thing I just want to add here, that in both the cases, some of the other, before the transplant, they have, when they were given sorafenib, that was giving a good risk, they are tolerating well. But post-transplant, some of the other, maybe underlying GVHD or some skin manifestation was there. Both of them had some problem with sorafenib, especially they have skin manifestation of their sole and palms, blister formation, both of them. And you have to stop the dose, or you have to taper the dose, because ideally you have to give 200 milligrams PD twice a day, 400 milligram per day. So we have to stop for a time being these sorafenib and then restart it with 200 milligram and so on and so forth. But till now, in these two cases, they are responding well. They are having more than, say, one have more than 1 year of transplant, and the other is now around about 6 months and so.
Thank you, sir. That's great to know. My next question is on benign hematological disorders, and we've not touched upon this topic in this session, and it's on thalassemia. And I'll invite Dr. Nasir Bukhari to speak about his experience in transplants in thalassemia, especially for class 2 or 3 thalassemic patients.
Thank you very much for giving me opportunity. My all teachers are here, and this was a great opportunity for me, learning experience. So up till now, we have done almost 50 bone marrow transplant in our center. And as you know, this is a government sector hospital, and we are performing bone marrow transplant free of cost. So we never refuse anyone for bone marrow transplant. Up till now, our data shows that our success rate is almost 83% in 01 and almost 72% in 2 or 3. We have some limitations as well, but we recently conducted a study, and it is an ongoing study, that we divided our patients in 4 groups. The first group was very low socioeconomic, the other was middle class, third was the upper middle class, and the fourth was rich families. And we saw that although we did transplants free of cost in all these patients, but due to post-transplant care, the very low socioeconomic group was unable to handle these transplants. So now we are thinking that if a person is even festive transplant is available free of cost, but the persons who belong to very low socioeconomic families, transplant should be considered again if we decide, because I think transplant is not a good option for those patients who belong to very low socioeconomic families, and unfortunately they will unable to handle these transplants. I don't know what is your experience about this.
Can I give you a suggestion, Dr. Nasir? In fact, it would be a pity to refuse a transplantable child. What you can do is, since you have government funding, and the government is receptive currently on the health issues, and the Sehat card, etc., has been launched recently. So what you can do is basically to basically arrange a place near your transplant center where the patient stays for 6 months post-transplant. This is what SIUT in Karachi has done, in fact, and are doing. They have a facility in Karachi. Somebody donated them a house, and they have a facility where they keep the patient not only from the lower socioeconomic group, but people who come from far-flung areas. Because if the person gets a transplant and go back to 600 miles, it would not be easy to do a proper post-transplant care. So you should utilize some of the government funding, which is a great thing to hear, that the government of Punjab is funding your unit. You can always ask for a facility to keep those patients for about 6 months or so post-transplantation, rather than sending them back to overcrowded homes.
Thank you, Dr. Salman, and thank you, Dr. Nasir, for your thoughts. Dr. Shahzad, I'm going to roll over the same question.
Sorry for interruption. Can I have a question from General Qamar?
Yes, please.
Sorry. Dr. Qamar, actually, I already said we are performing bone marrow transplant free of cost. So due to financial constraints, we sometimes use only cyclophosphamide fludarabine for conditioning regime in aplastic anemia. So do you have any experience of this in your center? Means without ATG?
Sorry, are we talking about thalassemia or aplastic anemia?
Aplastic anemia.
No, I'm afraid not. So what are your results like?
Means up till now, we have only 3 years data, and our success rate is almost 83%, but unfortunately about 20% patients relapsed when we stop their immunosuppressants, but still about 64% patients are good.
64%, okay. So of course, ATG does improve the outcome of transplants, and the upfront transplant, the first transplants were done with cyclophosphamide, but then again, when ATG was added, it improved the outcome. So I think it would be hard to, at the moment at least, without ATG.
Thank you. Moving forward, Dr. Shahzad, my next question is to you. As an upcoming transplant center, you're doing a great job, but we would want to know what kind of challenges do you face on a daily basis, and what are the solutions that you come up with to overcome those challenges?
Assalamu alaikum. Thank you, madam, for giving me a chance. And the first problem what we are facing is the training of our staff. Usually the staff over here is local nursing staff. They are not that much trained to handle these transplant patients. So what we have done for solution, we spend most of our time over here, and we do training multiple times. We do counseling sessions of patients in front of staff. We are going to take multiple classes of our nursing, and we are deeply involved in the management of patient ourselves. So we are not working like consultants over here. Rather, we are working like senior nurses or staff over here. So round the clock, we are available over here, and we are also making the chemotherapy of our patients ourselves. We have also replaced our pharmacists. So above all, madam, Sir Janapi is keenly observing us every time. So there are quite big challenges. Trained staff is a quite big challenge over here. And the other thing is that it is definitely that the people over here are very illiterate. So what we have done, one of our consultants used to visit the living place of the patient, and we keenly follow them after 2 days, after 3 days, and we repeatedly counsel them in their language. And we have conducted small sessions in their language, in Sindhi language, so they can take care of their patient, especially post-transplant.
Now, Shahzad, you mentioned about General Parvez looking after you. तो पाकिस्तान में तो ये होता है जो काम सही ना हो रहा हो तो फौजी संभालती है इसको आकर.
May I add something? Actually, we had the same problem.
Okay, so with this we come to the end of this session. It remains for me to thank all the speakers. Dr. Bipin is not here with us. Dr. Farrukh Awan, thank you so much. I know it's an awkward time for you, and so nice to hear your excellent talk. Really thankful to you.
Pleasure. It's a pleasure. And I just wanted to add one thing. Aapne jo kaha tha about how SAUT did. So just to share that experience, because this is a very unique, this is not a very unique problem for you guys. Even in Dallas, if you have been to Dallas, if you live in the outskirts, it sometimes can take you an hour or more to drive to our center. And we actually have the same issue, and we keep patients there for 2 months, anywhere from 30 days to 60 days, depending on their issues. And we have actually do that for all our patients who come from within town and outside of town. And because we don't have obviously unlimited space, we do work with the Ronald McDonald House, so McDonald Charities. We have worked with some local hotels, and they provide us free rooms or very subsidized rooms, and just local charities, and they provide apartments for us. So there are ways to improve outcomes, because I think post-transplant care is a huge challenge anywhere in the world. And if you can see the patient 2 or 3 times a week, and they can just walk to the hospital, it makes a huge difference.
Exactly. Agree with you. Thank you, Dr. Qamar Nisa Chaudhary, General Qamar Nisa Chaudhary, Dr. Ayaz Mir, and our panelists, Dr. Satti, Dr. Shahzad, and Dr. Nasir Abbas Bukhari. Thank you all very much for your excellent talks, and followed by a very healthy discussion. Thanks a lot. Thank you very much.
Thank you very much.
Thank you.
Allah Hafiz.
We're going to come back for the closing session in 15 minutes at
Prize
6 p.m.
distribution.
for announcement of poster presentation winners, oral presentation winners, and e-poster presentation winners. So
Right.
please join at 6 p.m. Thank you very much.